Good morning and welcome to the webinar. We are going to bring you some information regarding the general topic of robotic technology applied to the transplant of kidney and pancreas. So we have 4 talks covering most of the issue inherent to the field. We start with Dr. Spaggiari presenting our experience with robotic donor nephrectomy. Next, Dr. DeCock will talk about our experience with the robotic kidney transplant, the recipient side. Dr. Spaggiari will follow again, describing the approach of robotic pancreas transplant alone and combined with kidney in the treatment of obese recipient candidate for pancreas or kidney pancreas transplantation. And finally, I'll present the result of our trial comparing robotic kidney transplant alone with a combination of sleeve gastrectomy and robotic kidney transplant in the attempt to address not only the renal failure, but also the obesity that led to the health problem for our patient population. This is a problem particularly important in the US. As a general information for colleagues from other parts of the world, in Illinois, we have an incidence of BMI greater than 30, between 30 and 35%. Several states in the southeast of the United States, such as Mississippi and similar, have an incidence of between 35 and 40. So the national rate of obesity is about 33% as defined for BMI greater than 30. We believe that robotic technology may help the surgeon that is challenged with patient with high BMI and otherwise good candidate for either kidney and pancreas transplant. And during this next hour and a half, we'll bring to you everything we learned in the last 20 years, since the first time we did a robotic donor nephrectomy to now, and about 10 years experience with robotic kidney transplant. I hope you'll find that interesting and will be interactive. You will be allowed, of course, to ask questions, and I will open the forum to a question from the audience after each presentation, so it can be specific to the topic just discussed. With this, I would like to present to you Dr. Mario Spaggiari, one of our best transplant surgeons, that will address initially the issue of the result of robotic donor nephrectomy in our 20 years experience. Mario, please.
Thank you for the opportunity, and let me share my screen. Okay. Yeah, so thank you for the opportunity. So today I will talk about robotic assisted living donor nephrectomy, and I'm going to start with a very basic concept. So why and how we should do it. So the reason why we should do it is because, every time we have a person who would like to donate an organ, a kidney in this particular case, we strongly believe that we should make it happen. So donation usually starts with a strong desire, and it creates an incredible bond between the donor and the recipient. So for this reason, we strongly believe that as long that there are no medical contraindications, no technical or anatomical contraindication should stand in the way of the donation. And at the same time, donation by definition should be the safest procedure that we perform. It should provide cosmetically appealing results, minimal pain, optimal function of the donor, short hospital stay, and then of course it should preserve the function and the integrity of the graft that we transplant. So in order to provide all these features, so we think that we should use the best technology available. As everybody's pretty familiar, I'm sure, so the first minimal invasive nephrectomy was performed by Dr. Radner in 1995. And initially they were able to show not inferior outcome results between minimal invasive nephrectomy and the largest series of open nephrectomy for living donation. And then, of course, when the surgeon became more used to the procedure, more competent, of course, they were able to show better results in terms of hospital stay and outcome. And this became very appealing for the population because they had the chance to donate an organ with a minimal pain, very short hospital stay, and very important for a healthy person with a very good cosmetic results. And I call this slide the robotic transition. Is not really a transition because we know that laparoscopic nephrectomy is still the standard of care for donor nephrectomy and is part of the ESTS curricula. But in August 2000, so the group led by Dr. Benedetti performed the first laparoscopic donor nephrectomy. And I would like to cover the reason, the rationale to start applying the robotic technology to nephrectomy. Well, we all know the features of the robot. The end of wrist makes the dissection very easy, especially in the presence of difficult anatomies and multiple arteries. We have the magnification of the surgical field and the 3D vision in the surgical field. We have a stability of the camera that we control through the console, and we have a shorter learning curve than laparoscopy. All these features, they came to a hand when they had the vision to start robotic nephrectomy. And I think that nowadays they are even more important because the population of the donor population is growing more obese. And I want to add another point. So there are many centers where the robotic nephrectomy, the laparoscopic nephrectomy, is still performed by the minimal invasive division or the minimal invasive urologist. And the reason is mostly because as transplant surgeon, most of us, we had a maximal invasive training. So we are used to big operation, we are used to multi-organ procurement, big incision. And then, of course, the moment we approach the minimal invasive ward and we try to apply it in transplantation, so we want to use the best technology with the shorter learning curve. And we strongly believe that actually the robot provided all these benefits all in once. And talking about the technique, so I mentioned before that we think that the robot is better, definitely not inferior, but probably better whenever we have to deal with multiple arteries and, let's say, aberrant anatomy. So that's why I want to show you a couple of videos. So in this video, we have two arteries. We have a lower pole and a main renal artery, and we have a retroaortic renal vein. And this is how we perform the procedure. We always start with the mobilization of the colon that we can see here. So we expose the iliopsoas muscle to identify the ureter in its medial portion. After the ureter is identified, we encircle the ureter with a penrose that we use to facilitate the dissection and for retraction. At this point, we identify the gonadal vein that we follow in a distal to proximal direction in order to identify the renal vein. In this particular case, you can see that the renal vein is a typical caudal to cranial course simply because it's retroaortic. So usually the takeoff is a little bit lower than a regular renal vein. And as you can see here, we can see the lower pole artery crossing the gonadal vein and almost the renal vein itself. Then we keep dissecting proximally to identify the adrenal vein. That is there. So once it's identified, both the adrenal and the gonadal vein are transected between homologs. So gonadal is transected. And the adrenal is transected as well. I hope these videos are not long, but I know that this platform is particularly interesting for all the media that we share. So I hope that these are helpful for the audience. At this point, we transect the ureter. We mobilize the kidney immediately after we finish the hilar dissection. You can see the hand of the assistant in the field. And maybe I can. Okay, so now the kidney is medially mobilized. The dissection continues. Let me move this a little bit faster. So here we have the two arteries that we can see here and the vein that are ready to be transected. So we start the transaction of the accessory lower pole. We continue with the main renal artery. And then finally the vein, and as we can retrieve the graft. So some tips and tricks from a pure technical standpoint. So we know that the common anatomical variation are the presence of accessory upper or lower pole, or in this case, like retroaortic renal vein. So usually we suggest to not lose the natural exposure of the provided by the contraction of the gonadal and adrenal vein to dissect them both before transecting them. Because otherwise, if we transect one and we start dissecting the other, that's going to be more difficult. And another thing, usually we prefer to dissect the hilum entirely before starting mobilizing the kidney, because otherwise the kidney literally will fall into the hilum, and the dissection will be more troublesome. And in the presence of a retroaortic renal vein, we have to consider that sometimes the artery can cross in the anterior wall of the vein. So we have to be very careful during the dissection. And now I'm going to show you briefly a right nephrectomy in the presence of adhesion for an open cholecystectomy. So we start in the same manner. So we mobilize the colon.
Mario, sorry to intervene.
Yeah.
Please skip at the time. So
Okay.
if you need to show the video, do it very fast, okay?
Okay. So we saw before the IVC dissection and the dissection of the renal vein. Here we perform with scissor the adhesiolisis. At this point, it's very important in the right nephrectomy to flip the kidney immediately and to fully mobilize the IVC, because this is going to give us a better exposure in the artery. And sometimes we're able to dissect a good portion of the artery actually behind the IVC. So we can definitely gain some land there. And here we see the dissection of the artery, transection of the ureter, and finally we stapler the artery and the vein, and we retrieve the organ. I think I can. Okay. And again, so probably the key of the right nephrectomy is the full immobilization of the IVC to have a better access to the artery. And just another details, technical details. So end assistance, some center they like to do it pure minimal invasive. We still advocate for the hand assistant. And the reason why we keep doing that is simply because we think that every donor procedure at the end of the day will become a hybrid procedure, because we have to open up funnel or any kind of service incision to retrieve the organ. So we like to do it sooner rather than later, simply because we strongly believe that the presence in the field of an expert, experienced hand can be very helpful when we have difficult anatomy, obesity, or even if you want to set the threshold for conversion higher, because if you get in any kind of bleeder, a good assistant can literally stop the bleeder while we exchange the instrument and we literally decide what we're going to do next. So now we can move to our experience. So we recently published our experience on Annals of Surgery, and the experience, as I mentioned before, was started in August 2000, and we published about 1,000 cases. The conversion rate was 0.6%, and all the cases that were converted happened at the really beginning of the experience, in the first 5 years. We did 95% of left nephrectomy, and in 24% of the case, we had arterial anatomy variation. And unfortunately, we had one fatality for a congenital hypogammaglobulinemia in a patient that donated to his twin, that unfortunately struggled himself with a severe sepsis for the same reason, but the recipient recovered. Talking about the donor demographics, so the majority of our donors are female, about 55%. And ethnicity-wise, this is a good picture of the population that we serve here in the Chicago area. So 36% of our donors are African-American, followed by 27%, 31% that are Hispanic, and 27% that are Caucasian. So this picture about the BMI probably, is a reflection of what happened over the last 20 years, but probably if we check by decades, we would see probably more obese and morbidly obese patients. Anyway, since we started, 35% of the patients were overweight, 25% were obese, and about 15% of our patients are morbidly obese. I'm sure that nowadays are more than that. In terms of vascular variation, in 25% of our cases, we had 2 arteries, and in 3%, we had either 3 or 4 arteries. And about the hospital outcome, so the worming schema time with the robotic approach has been pretty much steady from the beginning, and it's about 3 minutes. The surgical duration, of course, improve over time. And intraoperative blood loss has always been minimal, and we transfuse only for patients for the reason that I explain later in the outcome. The length of stay, the median length of stay is 3 days, but nowadays usually our patients stay in the hospital. If they are very young and they're willing to go, usually they stay 1 day, sometimes they stay 2. And this is the complication by the Clavien classification. As you can see, we had 0.2% of grade 4 complication, and we have 1 grade 5, that is the mortality that I mentioned before. So the grade 4 complication were 2 intra-abdominal hematoma that required a laparoscopic washout. We had an hemoperitoneum due to an epigastric artery bleeding that required a fixing and a hematoma washout. And then we had a bowel perforation that was fixed on postoperative day 1. The other complications are minor complications, and in total, the complication rate within 30 days, it's about 17%. That is absolutely in line with what is reported now in the largest laparoscopic nephrectomy series. And we stratify our study by BMI classes to see if there is any impact of the BMI in the outcome of our donor. And as we can see here, highest BMI patients usually are female and usually are African Americans. If you're talking about the operative variables, so the OR time actually isn't changed, and no difference were noticed in the warm ischemia time, EBL, transfusion rate, or length of stay. So I think we can state that the BMI doesn't impact the outcome results of the robotic nephrectomy. And for this reason, I conclude that robotic living donor nephrectomy is a safe technique which offers the advantage of a short learning cure, shorter operating time, fast patient recovery, and we think better outcomes. And we strongly believe that the robotic nephrectomy is an excellent technique, especially with high BMI recipient and with anatomical variation. Thank you for your attention, and I will be happy to answer some questions.
Thank you, Mario, for the presentation. Yeah, we have been lucky enough that we didn't see neither conversion or blood transfusion since 2006. So the learning curve has been in the initial years, and now we have a very good operation. Can I ask if there is any question? I see some. Dr. Vinay Kumarar. Can we ask the organization to allow Dr. Kumarar to ask his question live? Dr. Kumaran, please go ahead.
Actually, your question was answered later on. I was just asking about the warm ischemia time, and the slide came up later, and I saw the warm ischemia time is 3 minutes. So
right.
It's 3 minutes,
and during your talk. Thank you.
It really hasn't changed over time, and I think, I mean, we have a very standardized way of doing this procedure, so that's probably why. And
all right, so we have a few other questions. Dr. Sameh Fayel, would you like to ask your question? Otherwise, I can read it. He's asking if we perform donor robotic assistant surgery with the hand in from the beginning of the case. And the second question is about the max BMI that we accept.
Yeah. So talking about the hand assistance, as I mentioned before, yes, we use the hand assistance from the beginning through a funnel still. And the reason is because, again, the kidney has to come out somehow, somewhere. And everybody take it out from a funnel still. So our point is why we don't put the hand inside from the beginning, because this is going to be very helpful for the exposure, especially in obese patients when we have to deal with a lot of bowel, and having a good hand inside, that's very helpful. It's going to make, you know, your operation go smoothly. And then at the same time, I think that the point is the threshold for conversion. So when you have to deal with the bleeders, sometimes it can happen, not often, but sometimes it may happen. If you have an expert hand inside that can tamponate the bleeding, then you can start, you know, making a plan. You can change your instruments, you can prepare your stitch, you have time. You don't have to rush to convert because you're in a situation that you have to fix quickly, and you don't have, you know, the strategies. I mean, the system in place. So that's why we do it from the beginning. We don't see honestly any reason why it should be done later, just at the time of the graft retrieval, because that incision has to be done anyway, right? And talking about the BMI cutoff, so we recently set a BMI cutoff of 45, but please, Dr. Benedetti, correct me if I'm saying anything wrong.
No, 45 is the right answer.
And that's our cutoff. So usually, you know, we know that we are dealing with a small group of patients that are obese, but otherwise very healthy. And there is a nice study from Doris Seder that actually tried to describe in a very epidemiological way, the outcome results of this patient. It's
Yeah,
very,
Mario, we have many other questions.
okay,
Please,
yeah.
let's try to answer as many as possible. I'm going to allow 3 more questions, and I start with Ellen van Ettelvelde. What is the trocar placement?
Okay, so the trocar placement. So we keep the, I'm talking now about a left nephrectomy. So the patient is in a right flank position. So we put one robotic arm in the left subcostal space, very high. Then we put the camera pretty much at the level of the midline, facing the kidney hilum. So we feel the kidney from inside, and we put the camera about 10 centimeter towards the midline. So the second robotic arm goes in the left patient flank at the same line, pretty much, the mid clavicular line, in the same line of the first robotic arm. And then we put the assistant trocar that is a 12 millimeter in the left iliac fossa.
Very good. So there is another interesting question from Dr. Qiang Liu. Any cost-effective analysis? This one I'll answer because we took care of it before Mario's time. So we did initially a cost-effective analysis comparing robotic donor nephrectomy to open, and it's a clear-cut win for the robot despite the additional cost of the procedure because we save a length of stay that was back then 3 days less on the robotic side. The same, of course, all true for laparoscopy. When we compare laparoscopic versus robotic donor nephrectomy in our hospital, we found a comparable cost. The reason is we don't use very sophisticated instruments. We just use the hook and the bipolar. One of the person in the audience was asking, can you use energy device? Dr. Cariala Raivin, can we use the new energy device to divide the vein instead of clip? Of course you can, but then you add cost to the procedure. We believe that the robotic clip are easy to apply. They have a 360-degree rotation, and they're very safe. And we keep also an eye on the cost. And if we do with this simple baseline instrument, no energy device, just the hook and the clips, we actually are comparable at the cost of laparoscopy in our hospital, which we like to have to continue the support of the administration. I'm gonna go through one more question, and then Dr. Spaggiari will respond by text to the individual questions that are not been replied yet. Dr. Asha Zimmerman, by requiring hand inside and someone on the console, do you always do these cases with 2 attendings?
We usually the hand assistant most of the time is our fellow. They become very proficient because we do many of those cases. So we like to have 2 attendants sometimes, but is not a rule. The hand assistant, I mean, it's something that can be done by a very proficient fellow. So maybe the first year we don't allow them, we teach them, and the second year they can be already excellent assistant.
Last question that I'm going to address is from Juan Carlos Caicedo. How do you assess the long-term risk of morbid obese prior to donation? That's a great question, Juan Carlos. So first of all, we use only IOXL to check the GFR of potential donor, which, as you know, is considered the most accurate system currently available. And we are very conservative in accepting only donor with excellent GFR documented by IOXL. We have a of course, a transplant nephrology consultation before that point out to them the risk linked to the obesity, either direct or indirect, regarding our kidney function. We have a social worker as well as the patient representative that pretty much go once more over the risk inherent to being obese and donating one kidney. So we try to be as open as possible and try to be as selective as possible from the standpoint of the renal function and the overall operative risk. I hope I answer, otherwise we can continue offline. At this point, I will ask Dr. Spaggiari to respond to the remaining question directly by text. Mario, please take care. And I would like to invite Dr. Di Cocco to present our experience with robotic kidney transplant. Pierpaolo, put your video on and present. Thank you.
I'm going to load my video. Good morning, everyone. Thank you for the opportunity to be here. And I'm going to present on, sorry. Is a chat window. I'm going to present on robotic kidney transplant in recipient with IBMI. So transplantation is a highly successful field, with kidney transplantation in particular being considered treatment of choice for end-stage renal disease. The open procedure is still considered the gold standard, with at least short-term result very close to 100%. Therefore, the application of a new technology, in this case robotic, has to be at least as good as the gold standard. The current scenario sees market penetration of transplantation still less than 1%, with pioneering centers paving the way for its expansion. And over the last 25 years, they adopted several techniques. Most of them will be discussed in today in our webinar. The first application of robotic surgery in kidney transplant is a relatively recent introduction in the early 2000s by a French group. They described a hybrid open robotic kidney transplantation. So the access was performed through a standard open incision, and the robot was docked and used for dissection and exposure of the iliac vessels, vascular anastomosis, and the last part of the transplant, so the ureteric anastomosis. The operation was uneventful, with a cold ischemia time of 26 hours and operative time just below 3 hours. Vascular anastomosis time was 57 minutes, so the warm ischemia time. What we know from the reviewing the literature is that transplantation has a large room of improvement in the setting of obesity. We do know that obese candidates are less likely to be listed. Once listed, they continue to face decreased access to transplantation with high rates of waitlist removal, a low likelihood of transplantation, which translates in longer time spent on dialysis. They have, while on dialysis, risk of 5 to 15% of mortality per year, depending on the comorbidities. As we mentioned earlier, Dr. Benedetti mentioned earlier, the obesity is a relevant clinical problem, and has assumed a pandemic diffusion, with around 13% of the world population affected by various classes of obesity. Actually, the world population with obesity is 650 million of obese as of 2016, which is projected to reach 1.1 billion in 2030. In US, where the overall prevalence is around 33%, the situation is even more alarming, as we can see in this slide. Half of the states see positive trends of overweight, which are highlighted in yellow, and the remaining half, there is a positive trend of various classes of obesity, highlighted in red and dark red. We do know that obesity it's related to an increased incidence of surgical complication. In the transplant field is not an exception. Lynch et al. In an article published in 2009 on anal surgery in their retrospective large series show that surgical site infection is an independent risk factor for having a negative impact on graft survival. And the same authors found a linear relationship between BMI and risk of surgical site infection. The higher the BMI, the higher the risk of having a surgical site infection. This slide shows the detrimental effect of surgical site infection on outcomes, irrespective from BMI. The blue arrow on the bottom will depict the outcome in patients with surgical site infection. The top one, which is interesting to notice, is that even obese patients without surgical site infection have a comparable outcome with a non-obese group. Based on the findings present on the literature and the previous findings, at the University of Illinois program was formulated the following hypothesis. So minimizing surgical trauma by using robotic technology could reduce wound infection and improve outcomes of kidney transplant in the setting of obesity. This hypothesis led to the first robotic kidney transplant described in 2009. Was a full robotic assisted kidney transplant in a morbidly obese patient with BMI of 41. The transplant was uneventful, immediate graft function, and discharge on day 5. This led, of course, to the publication, recent publication this year of our 10-year experience. 248 patients were considered. We had 9 conversions, and the analysis was performed in 239 transplants. Demographics, 57% were male with a mean age of 47 years. As mentioned before, the African American population is the most represented with 53%. The remaining half is equally distributed between white and Hispanic. Distribution by BMI, 55.6% of our patients had a BMI above 40, 27.8% BMI between 35 and 39.9, and the remaining with a BMI less than 34.9. Sorry. The 166 transplants were performed with using living donors, 63.9% living related, and 10.2% swaps. 73 patients were from deceased donor, with of which 17.8% DCD. The mean KDPI was 42%. Large part of our patients were on dialysis prior to transplant, 78%, and length on dialysis was pretty long. The mean time was 54 months. Positive cross-match patient in 9.8%, ABO incompatibility in 4.8%. They were all living donor, and they all underwent desensitization protocols. Characteristic of ischemic time, warm ischemia time, the median was 46 minutes for deceased donor, 44 minutes for living donor, with an overall of 44 minutes. The cold ischemia time was 14 hours for deceased donor, 1.3 hours for living donor. The overall time was 2.1 hours. The delayed graft function rate was 23% in deceased donor, 17 patients, 3% in living donors, only 5 patients, with an overall percentage of 11.3. hours. 25 of our patients had concomitant surgery, mostly hernia repair, 14 patients, bariatric procedures in 6 patients, and the remaining 4 had splenectomy, 1 cholecystectomy, 1 salpingo-oophorectomy. The median length of stay for our population was 5 days. Reoperation rate within 30 days, 12 patients, unfortunately, were reoperated within 30 days. 2 grafts unfortunately removed for vascular thrombosis or accelerated acute rejection. 5 patients required ureteric reimplantation due to leak. 1 patient for bleeding from the hilum, and 1 exploratory laparoscopy. The 3 cases which underwent splenectomy earlier on in the first 30 days were not included as a surgical complication, as the splenectomy was performed for treatment of refractory antibody-mediated rejection. The 9 patients which had a conversion, 3.7% of the total, were mostly for suboptimal graft perfusion. Of note, all of them had multiple arterial anatomy for patients. In 2 cases, the conversion was because of the tenacious adhesions was preventing safe dissection of the iliac vessels. Other 2 patients were converted because of vascular complications, so the dissection of the iliac artery, and last conversion because of venous bleeder. The wound complications are in 9 patients, 3.8%. With a surgical site infection of 0.4%, only 1 patient had documented the surgical site infection. This is an exceptional result, considering that the patient population in the literature has a reported incidence of surgical site infection anywhere between 20 and 40%, considering the class of obesity. Our overall graft survival was 98% at 1 year and 93% at 3 years, with overall patient survival of 98% at 1 year and 95.3% at 3 years. When comparing our results with UNOS data, we had a similar survival statistic compared to open kidney transplant from living donors over the same period. Our results are in line with the living donor result in the nation. Looking at UNOS data and living donor kidney transplant over a 5-year period between 2009 and 2014, we do see that over 32,000 living donor kidney transplants were performed, and transplant in patients with BMI over 40 were only in 1.9%, just above 600 cases. This to document that the obese population is underserved. And in the implementation of a robotic technique at University of Illinois led the program to perform in the same time period 12.7% of the transplants in BMI more than 40 and 15.9% in patients with BMI of 45 in the nation. In our experience, robotic kidney transplant is an effective approach to reduce wound complications in obese recipients, allowing safe and successful transplantation for patients which had previously denied access to transplantation. And before concluding, I would like to show a short video of the technique of robotic kidney transplant, which is an intraperitoneal approach for right side implantation. The access is gained with a midline incision, 7 to 10 centimeters subxiphoid. And the first step is the dissection of the iliac vessels, artery first, to follow dissection of the vein. Vein is clamped with robotic bulldogs. Penotomy is performed, and here we do see the anastomosis, which is done with the Robotics running suture. Next step is the arterial anastomosis, same clamp of the external iliac artery between bulldog. The anastomosis is fashioned in the similar way with a running suture with Robotics. So the robotic kidney transplant has been performed in different ways. Some authors prefer cooling the organ, we don't. Here we see the reperfusion with minimal blood loss, and kidney drinks up nicely. And next we do perform an ICG test to document perfusion. In this case, was a good global perfusion. And the next step is the ureteric anastomosis, performed with PDS running suture. We do place routinely stent in order to facilitate the healing process of the anastomosis. Okay. Thank you, everyone, for your attention. I don't hear anything.
Yes. So we are going to start the question I see starting from yeah, I would ask, by the way, if you could just sign your question, because I don't see your full name. I see Daniel Jacobs /T asking, do you consider bariatric surgery before listing the patient? Pierpaolo, please address.
Sorry, I'm trying to log in. Okay, so that's thank you for your question. That's a very interesting question. As you will see in the next presentation, we do have in place a strategy to treat the obesity as a concomitant procedure during transplantation with a robotic sleeve gastrectomy at the same time of the transplant. Doing the operation before the transplant is certainly possible. Recent data showing acceptable rates of morbidity and mortality, but still is in patients with end-stage renal disease with a higher incidence of mostly morbidity related to the procedure itself. And what is recently done in the literature is the Roux-en-Y is out of favor, and most of the centers performing sleeve gastrectomy instead.
Yeah, this particular topic about bariatric surgery, I will address extensively with the last presentation. So if Daniel has a little bit of patience, we will talk a lot about bariatric surgery before listing. Dr. Lloyd Ratner, Lloyd, good to hear you. Where do you place the ports, and what size ports do you use? Pierpaolo, you should know that well.
Okay, so the right arm of the robotic port is placed for a right side implantation on the right upper quadrant. The robotic camera, we usually place in the periumbilical area, and left robotic arm will be placed in the left lower quadrant with an additional assisting port of 12 millimeter placed in between the robotic camera and the left arm. It's optional, the placement of a third robotic arm, which can be placed in the left lower quadrant, and this is helpful in helping during the fashioning of the ureter, or in females where there is a bulky uterus, and it's helpful in that setting.
Dr. Ratner was also asking the size of the port that you use.
Oh, the sides, I'm sorry. So the robotic ports are 8 millimeters and assisting port 12 millimeters.
Very good. The next question is coming, again, I don't see the last name, I'm sorry, but how kidney is cooled while doing anastomosis? I'll take this. We do not cool the kidney. We actually just let the kidney be in the intra-abdominal situation with sort of relatively cold CO2 coming, and we did not suffer any problem with that. I know that other centers have gone to extreme to try to cool the kidney while doing the anastomosis. As you've seen, our average warm ischemia time is 44 minutes, which is slightly higher than, let's say, a open kidney transplant done in non-obese individual, but compare very well, even in open fashion, with the anastomotic time for morbidly obese individual. So we did not use any cooling system, and we do not believe it's necessary. Dr. Osama, Ahmed Osama asked, is the Gore-Tex suture a must? Why? Well, we learned from our top robotic surgeon, Dr. Giulianotti, who pretty much established the technique for vascular anastomosis done with the robot using Gore-Tex. I must tell you that in my mind, it's a must, because it resists better to manipulation and has a very good ability to be tight without difficulties. So we definitely prefer the Gore-Tex suture. Not a must, you can try with Prolene, but you may be in trouble because Prolene may break easily during the running anastomosis, while Gore-Tex, if well handled, almost never break. Pierpaolo, Daniel Jacobs tool, sorry. Is it more difficult to perform biopsy intraperitoneal position kidney? Please comment how we do it.
Well, that's a good question. Thank you for your question. So in robotic kidney transplant, we do perform laparoscopically those biopsies. Doing it percutaneously, there is a high chance of having an intraperitoneal bleed, but with the laparoscopic approach, it's usually an easy procedure. It requires a general anesthetic, but that's the
yeah. So the Gore-Tex question came from my friend Osama Gaber. Osama, thank you for signing. That's why it's important to sign, because I just see part of the name. The next question, actually, Sarbrit asked to speak. Can you give the ability to speak at Ajit Wilgal?
okay.
Please go ahead, Dr. Wilgal.
This is Dr. Ajit Wilgal from Bangalore, India. I have three, one question and two that I noticed. When you need to reopen for complications, do you do robotic surgery again, or do you open up? One. Second, I noticed you do an arteriotomy on the external iliac artery using scissors and not a punch. Any particular reason? And three, I'm also surprised to see that you had a 2% urinary leak in spite of using stents.
Thank you, Dr. Wilgal. So first of all, we do always the re-exploration with robotics. For example, the 5 ureteral leak that we had in the up to 2012, so in the initial 2 years of our experience, we repair robotically. Clearly, going back to Dr. Osama Gaber question, the PDS is a frail monofilament suture. And we made the mistake at the beginning of manipulating the PDS with not enough care, and we had breakdown of the suture line, which we repair robotically. In terms of the arteriotomy, we found ourselves very well served by placing a stage suture and then cutting a cuff of the size that we want of the iliac artery. And we have done successfully now 340 times. So we don't need the punch. We don't use the punch even in open surgery. And finally, the leak, I think I explained you the reason. The learning curve. We didn't realize that managing the monofilament suture, the PDS, with the robot where you don't have tactile feedback, you need to have a special care. And now we do with the slightly larger suture for PDS, and we are extremely careful not to touch the portion of the PDS that will be part of the anastomosis, because that was our mistake early on. Again, the last time we leaked was in 2003, something like that. Sorry, 2013, something like that. We didn't leak for many years once we figure out that part. Any other question, Dr. Regal?
Thank you. That's it. Thank you.
Very good. As you can see, you can either speak or just put your question on the text. Dr. Oscar Serrano asked, how long is the warm ischemia time for the anastomosis? Pierpaolo?
So in our disease donor group was 46 minutes on average, and in the living donor group was 44.
Good. And Dr. Kadiyala Ravini didn't sign. Please describe experience with multiple donor arteries. This one, I'll take it. So we did about 24% of the cases as kidney with multiple arteries. In majority of the case, we simply reconstruct to a single arterial conduit using either end-to-side or side-to-side technique. In a small number of cases, we reimplant separately 2 renal arteries. We do typically that if the arteries are apart and the renal vein is in between them. We found that up to 2 reimplantation can be done quite readily. We did not ever try to do more than 2 out of fear of prolonged warm ischemia time. Dr. Chris Fresh, I'm sorry again, please sign. How do you handle a patient with calcium in iliac in terms of clamping and performing anastomosis while calcific plaque in the way? Pierpaolo?
Okay, so I didn't mention that. That's a good question. Thank you. The calcification of vessels is a relative contraindication, and in the setting of calcified vessels, we usually don't perform the operation. And once we detect calcified vessels during the operation, we can sometimes, if the robotic clamps are not holding, we could use small clamps placed through the end assistance. But as a general rule, in robotic, we tend to exclude patients with calcified vessels.
Yeah, Pierpaolo responded well. We do not perform the robotic kidney if there are calcification of the external iliac. We end up doing this obese patient open, and I can guarantee you, we actually prefer to do with the robot. We still do a large number of obese with calcified iliac artery open, and I can tell you it's a different world for the surgeon as much as for the patient. The next question comes from Dr. Rauf Shabazov. Do you place the kidney retroperitoneal after transplant or leave it intraperitoneal? Pierpaolo.
We do leave the kidneys intraperitoneal. There are descriptions in the literature of creating a pouch of peritoneum and then closing the kidney back. But we prefer not to. Our approach is to leave the kidney falling in the iliac fossa, and which facilitates also performance of the ureteric anastomosis.
Ellen van Etelvelde, where is the incision to introduce the kidney?
The incision is on the as high as possible in the midline subxiphoid, so 7 to 10 centimeters.
There is a question, I cannot read the name, I apologize. Do you fix the kidney when you put it intraperitoneal? I think Pierpaolo already responded, we do not fix. We take particular care to place the arterial and venous anastomosis strategically, and we actually try the kidney in all the position, full lateral, full medial. And if you do the positioning of the anastomosis well, the kidney should be well perfused in any position in that arch. Oh, we have actually a message from the president of ASTS, Mariwan. Mariwan, thank you for being present. The question is something that I would like Dr. Spaggiari to address. How to incorporate it, fellow training in a robot program. Mario, why don't you address that?
Okay. Yeah, well, I think that Pierpaolo is a living example of how we incorporate the fellow in the program. So first of all, the fellow needs to be trained in the lab. He needs to be familiar with the robot. And then usually we let the fellow do the bedside assistance that requires quite of skills, because there are many things that the fellow has to do. And actually, Pierpaolo became extremely proficient with that part. Then usually the next step is to start the dissection of the vessels. Start the dissection of the sternocleidomastoid artery and vein. You know, if you have the chance to have the double console, that's excellent, because basically you can literally point where the fellow should go. You can take over the instruments if needed. Or for example, we have the screen that we can literally draw and basically put arrows, sign, and everything. So it's a very controlled training system. And then, of course, you know, after the arterial, the vascular dissection, the next step would be the ureter. That I think probably is the most complex anastomosis, but at the same time, it's not time sensitive. And then the rest. But, you know, the key is the lab at the beginning, at least to start with the vascular anastomosis and the bedside assistance to get used and proficient, you know, with the robot and with the machine.
I have an interesting question regarding what's the future of robotic kidney transplant in non-obese recipients. I'll take that. Well, we have chosen never to do the operation in non-obese individual. I was asked to perform a kidney transplant in Brazil during a visit with Dr. Di Cocco, and they showed to us the BMI 19 patient, and you can do it easily. It's a lot easy. If you're used to do obese, if you try to do the operation in a normal weight individual, it's very simple. I believe that in the future we could consider, although I'm a big proponent of the standard operation for people with normal BMI, it is hard to beat extraperitoneal approach, low incidence of complication, perfect exposure, cosmetic. Dr. Ratner has shown us a beautiful series of mini incision for kidney transplant. So I think to extend to non-obese, I will need some convincing. I like one approach that was proposed by a colleague in Europe from actually Sardinia, Italy, where they did the operation with the robot for athletes. They don't want any injury to their abdominal musculature. Of course, you can extend to say nobody wants any injury to any abdominal musculature. No one of us would like that. So I do not close the door to future more extensive use of robot in non-obese. But for now, I believe that the game changer is in obese individuals that benefit tremendously with the extraordinary reduction of wound infection and better outcome. I hope I answered to the question. I have a question from Dr. Arun Verma. What is your experience in using robotic implant in second or third transplant, retransplant? Pierpaolo.
I didn't provide data on the retransplant, but in the second transplant, it's easily done, shifting the ports for the left side, and for the third transplant, it's a challenging procedure, I believe.
All right. Martin Ersl. Hi, Martin. Do you do non-contrast CT scan in preparation for recipient surgery? Well, we do as a routine, as UNOS mandate, because of course the presence of calcification in iliac artery change your expected outcome. And we use that scan for planning robotic versus non-robotic. In patient on dialysis, we also do a IV contrast to study more precisely the external iliac artery and vein. Mahmoud Obeid. Have you used the internal iliac artery for arterial anastomosis? The answer is no. I have a few questions regarding the sleeve gastrectomy and kidney transplant, including my friend Michael Prieto. I will reserve to answer when I present on the trial robotic kidney transplant versus robotic plus sleeve gastrectomy. I believe that we answer most of the question. Pierpaolo, please check the list of the messages if I miss anyone. And I would like now to ask Dr. Spaggiari to come back and present on the robotic approach to pancreas and kidney pancreas transplant. Pierpaolo, please.
Mario.
I meant Mario Spaggiari, I'm sorry. Mario, go ahead.
Yeah, 1 second. Okay, thank you again for the opportunity. And now we're talking about robotic pancreas transplantation, our preliminary experience. Of course, I mean, we should start initially with the rationale, so why we started doing this. And I think we have multiple reasons. First reason is the increasing prevalence of obesity in type 1 diabetic patients. And the type 1 diabetic patients are not spared from the obesity pandemic. And as you can see in these slides, more and more diabetic patients are becoming obese. Then the second point is definitely what happened in 2014. So the new allocation allowed type 2 diabetic patients with some BMI restriction to have access to simultaneous pancreas and kidney transplantation. And actually recently, even the BMI restriction fell. So the access for type 2 diabetic patients, most of them are either overweight or obese, is higher. And that's something that we see from this slide. So since 2014, more type 2 diabetic patients have been listed for simultaneous pancreas and kidney transplantation. However, if we check, the BMIs of patients who receive a pancreas and kidney transplant, that actually it's pretty plateau, hasn't changed much. So still, there are probably many diabetic patients with low C-peptide that definitely require the pancreas, but they're just not transplanted. And then the other point is the faster recovery and the reduction in surgical sign complication. So this paper showed in 2015 that the BMI matters when we're talking about pancreas and kidney transplantation, especially because most of the center, I think pretty much everybody, they do this procedure through a midline incision that, as we know, it's a very morbid incision, and the incidence of surgical site infection it could be particularly higher. And then I put this picture that I think it's self-explanatory. So by replacing a midline incision, unfortunately, the quality of this picture is not very good, but there are not many midline incisions around at UAC these days, if I can make a joke. And our subxiphoid 7-centimeter incision, well, of course, the chance of having any kind of trouble with the incision is definitely higher in this particular situation, regardless of the BMI. And then the last point is definitely, we started, out of our experience with robotic kidney transplantation. Our experience that was just described by Dr. Di Cocco, that was recently published. So we apply pretty much the same technique with very minor variation. And we were proficient, and we felt that transition to pancreas transplantation was just a natural move at some point, and we felt, of course, the need. And talking about the technique, we place pretty much the port in the same way of robotic kidney transplant. So the pancreas goes to the left side with the head down, simply to keep the alienation of the artery and veins between the graft and the iliac vessel. We usually use for the insertion of the graft the usual 5 to 7 to 10 centimeter subxiphoid incision. We place a robotic right arm in the left subcostal space. The left arm is in the right iliac fossa. The camera here it says 12 millimeter, with the robotic XI is actually an 8 millimeter. And the laparoscopic assistant is in the right patient flank. Of course, the key is the position of the patient that has to be in a steep Trendelenburg position, rotated to the right, in order to not have all the bowel in the way and to expose the iliac fossa better. This is a little bit old video, so I think I'm just going to show you the pancreatic part. So we promised ourselves to do a new one, but we haven't done yet. So I'll show you this. Maybe some of you already saw it. So the dissection of the sternocleiac artery vein, as you can see, it's very similar. It's pretty much the same procedure that we do for robotic kidney transplantation. And once the dissection is completed, we hook the artery to the abdominal wall to facilitate the dissection of the sternocleiac vein. And then we do the usual venotomy. And we bring the pancreas in the field, as you can see, with the head down, and we start performing the portal anastomosis in the same fashion of our kidney transplant. Same thing about the artery. The Y graft reconstruction is, of course, absolutely the same that for open pancreas and kidney transplantation. And in terms of here is the reperfusion of the organ. The key is the benching for this procedure, because of course we can't allow bleeding at the reperfusion. So in this particular case, we did anastomosis in a mechanical fashion. Recently, we just do it manually because we think that actually the results are better. I'm not going to show you the kidney because you saw it before, but I would like to show you our results from our preliminary experience that we recently published. Since the beginning of robotic pancreas transplantation, we performed 13 cases and we published the first 10 cases that had at least 12 months of follow-up. It was a retrospective analysis. The study period was from 2015 to 2018. We did a match a match comparison analysis between 10 robotic assisted cases versus 39 open pancreas recipients performed at the same time, in the same time frame. And I think, oops, okay, sorry. So these are the patient demographic. What I would like to point out here is that 60% of our robotic cases were in African American patients, compared to 23% for the standard procedure. And the BMI was significantly higher in our robotic population because, we did this procedure basically for obese patients for the same principle that we applied for robotic kidney transplant. And comorbidities were pretty much the same. In terms of donor characteristics, not much difference in both groups. For some reason, all the 10 robotic cases came from male donor, but that was just pure chance. And in terms of operative details, probably the only difference that I would like to mention, the significant difference, are the enteric diversion. So in the robotic case, in 3 cases, we did duodenal cystostomy because basically the bowel couldn't reach. The bowel couldn't reach likely because of the position of the patient, maybe the length of the mesentery, but likely because of the steep Trendelenburg that sometimes makes, bringing the bowel down a little bit more difficult. So we found it easier to perform a duodenal cystostomy. So that's, one of the main differences. The blood loss is less in the robotic cases. I'm not quite sure about that, maybe because of how we do the back table and all the small details that we do every time we do a robotic case. And the warm ischemia time is, of course, a little bit longer compared to the open cases. In terms of outcome, the length of stay, it's a little bit shorter with the robotic. Of course, considering the small number of cases, there is no statistical significance here. Graft loss, we had only one graft loss that I'm gonna describe later, but it was pretty much a case of non-compliance. And the creatinine at follow-up was absolutely comparable between the 2 groups. And the 1-year graft survival was excellent in both groups and definitely in the robotic group. Complication-wise, surgical complication, we had 1 incisional hernia in the subxiphoid incision in the robotic group, and definitely we had more complication, more wound-related complication in our open group. We had a seroma in our open group and vascular complication. We had venous thrombosis and iliac pseudaneurysm in our standard group, nothing in the robotic group. In terms of graft loss, as I mentioned before, we had a patient that all in a sudden stopped to take the anti-rejection medication almost 2 years after the transplant and lost the pancreas. The rest of the graft loss in the open cohort, you can see the reason for graft loss is described here. So in conclusion, and this is actually the metabolic outcome at 12 months, as you can see, the hemoglobin A1C was excellent in both groups, robotic and open. So in conclusion, within the robotic pancreas transplant is definitely not inferior outcome compared to the standard approach, definitely has better cosmetic results, and we think that it has the potential to increase access to transplantation for obese diabetic patients and the minorities too, because of course we know that the obesity rates are different across different ethnicity, and this can kind of downplay some of the minorities. So we think actually that somehow the robotic pancreas make the procedure fair. Thank you. And this is our team. Of course, I mean, it takes robotic simultaneous pancreas and kidney transplantation. It's a team effort. we like to use two teams to perform the pancreas and the kidney, because otherwise the procedure would take longer. And this is our team with the new addition of Pier Paolo that joined the group recently after 3 years of fellowship, where he performed excellent and pretty much assisting all the cases. Thank you.
Very good. Thank you, Mario. Nice presentation. I do not have any specific question. Oh, here we go. We get one from Ricardo. In robotic simultaneous kidney pancreas, what's the sequence of implantation? Kidney first or pancreas first? Sarbrett Singh, Dr. Singh. Mario?
So we usually do pancreas first, but honestly, there is no rule. So if we have, or sometimes we use imported organ, and if we have a longer cold ischemia time, actually sometimes we like to put the kidney first. So there is not a rule. That's a decision that we made according to the cold ischemia time. Usually we do pancreas first, but that's definitely not a rule.
Very good. Ricardo Gontillo is asking, do you use different heparin dose for SPK robotic?
No, we don't use different heparin dose. So sometimes we do some heparin drip in the post-transplant time, but we don't use different heparin dose.
All right. Adarsh Vijay, any reason why you do not prefer finest incision for end port? Take it away, Mario.
Yeah, well, it would be extremely difficult with the hand there, to properly expose. And I think it would be very difficult to perform the bladder anastomosis with a fan steel incision. So basically, we couldn't exploit the service incision like we do with the subxiphoid. With the subxiphoid, besides inserting the organ, we have a beautiful exposure upward of the bowel. We have all the range of motion that we want in the pelvis to perform the bowel and the enteric diversion, the ureteroneurocystostomy. We think it's better. Plus, in an obese patient, a fan steel incision increase the chance of infection. So we like to do subxiphoid because that's an area with a very, very smaller risk of infection compared to the fold of the belly down there.
Yeah, I would say that that would be my answer. The fan steel incision would be in a part of the body with very thick pannus, because again, even the pancreas we do only for obese individual, and that's an area where the wound infection would be more likely. We like to stay away from the lower part of the abdomen for logistical as well as infection prevention reason. Oh, I have Lloyd Ratner. Lloyd Ratner, have you done any pancreas with head up and enteric anastomosis? Lloyd, so far we didn't. It's the lineup of the vessel with the pancreas on the left side facing down. We have the advantage to have the vein medial, the artery lateral, with match perfectly well the position of the portal vein and the arterial conduit. So we like to do that way. For small pancreas, and Mario's published about using pediatric donor, we consider to put the pancreas head up on the right side on the external iliac artery and vein. Then in that case it would match. But so far we didn't have the right case to do that. Tai Dan, hi Tai. Can you comment on where you put the kidney? Ipsilateral to avoid moving the arm? Curious why left is better.
Left is better because in the open fashion we put the pancreas on the common iliac and the distal IVC. So in that case, the orientation of the vessel is just excellent. But in the robotic fashion, we use the external iliac vessel. So in this particular case, going to the left provide the alineation of the vessel. So vein to vein and artery to artery without crossing. And
he's asking where we put the kidney.
Where we put the kidney. So the kidney goes in the external iliac artery and vein in the right side. And yes, some of the wear time is due to moving the robot, but that's something that's a problem that we had. So redocking the robot and move the patient. I think, you know, with the previous robot, with the XI, we still have to disconnect the trocars and move the patient in the other position. But at the same time, we don't have to move the entire machine because the machine, you know, it can accommodate itself to works in all the quadrants. So we save some time with the new machine. But yeah, we have to do it. We have to redock to the other side.
Very good. I don't see any other question. If anybody wants to make a comment, just raise your hand and we will, of course, be happy to allow you to comment. If you don't have a question but a comment, just ask to speak, please. Otherwise, we'll move on with the program. And now, oh, hold on a second. Dr. Sarpreet Singh asked if we have any experience with live donor kidney pancreas with the robot. Mario.
Well, so live donor pancreas, it's something that I don't have any experience. If I'm a little afraid of the concept, but actually I would leave this answer to Dr. Benedetti.
So we do have a series of 15 simultaneous kidney pancreas from living donors. So we have the know-how to do the operation. Of course, to have the perfect alignment of planets to do a simultaneous kidney pancreas is something that is not common. You need to have the perfect donor, you need to have somebody willing to risk the double operation and so forth. Furthermore, nowadays in the US, it's very easy to get the cadaver pancreas because the number of pancreas transplants, for a reason that I do not fully understand, has actually decreased. So we do not have a strong rationale to continue to do living donor kidney pancreas. We did do with the robot 2 donor, whereby the distal pancreas and the left kidney were taken in the same setting from the donor for the transplant. I don't think it would be an easy case to be done with the robot because I guarantee you that even open is very challenging. Lauren is asking, obese donor, do you still use the fan steel incision? You're talking about, if you hear me, the obese donor. Oh, yeah, we do use it for the donor nephrectomy. We use the suprapubic incision, yes. The orientation of the robot is opposite, is in the upper part of the body. So in this case, it's easier to come from below. Very good. I think we have exhausted the question, and maybe I will share my screen. For the final presentation of the day. So I'm going to share with you the result of a randomized trial that we conducted at the University of Illinois comparing robotic kidney transplant alone to robotic kidney transplant and sleeve gastrectomy, of course in recipient with BMI greater than 40 to be precise. Mario touched on the fact that, and Pierpaolo, that the effect of obesity on the outcome of kidney transplant is quite relevant even in the long term. There is no doubt that weight gain after transplant has a negative impact on post-transplant result. And we know by experience that many patients tend to actually gain more weight, even in the era of minimization of steroids. There is plenty of evidence. I just pick one article to show that the increased BMI actually make a difference in patient and graft survival in the long term, as demonstrated in this series from the Netherlands. I responded actually initially to a patient request. This is a long-term patient of mine that when he came to see me, say, would you be able to do a sleeve gastrectomy when we do my living donor transplant? So I thought about, and based on the fact that we have a pretty good track record in our bariatric surgery program, that is one of the largest in Illinois, and we have very good bariatric surgeon, I decided to say yes. And I was very impressed with the outcome at 6 months. That's the same lady with normal kidney after shedding about 12 points of BMI. So actually, I decided to open a randomized trial, IRB approved, in which we randomize patient with BMI greater than 40 to either receive robotic kidney alone or combination of robotic kidney and sleeve gastrectomy. Just to answer the question that was asked previously about our behavior in relation to obesity, of course, if the BMI is greater than 30, we consider candidate for robotic approach. If patient have calcification is not a candidate, we go to open kidney transplant. And the candidate for robotic approach we offer the combined sleeve and kidney transplant. As a policy, any patient with BMI greater 35 that asks for consideration for transplant in our center is immediately offered the opportunity to undergo bariatric surgery. We had actually our dietitian studying the issue, and she found that approximately 20% of the patient when offered agree to see our robotic surgeon, and about 8% get sleeve gastrectomy or sometimes gastric bypass before transplant. I can tell you that the success rate in obtaining the consent of the patient for the dual procedure is much greater. It's probably nearly 70%. As I said in other occasions, they cannot resist to the opportunity to have a 2-for-1. The way we do it, we pretty much minimize to only 4 to 5 ports. The ports are placed strategically in this mid-section of the abdomen. And initially, we orient the robot upward for the sleeve gastrectomy, and then we simply turn the robot downward for the robotic kidney transplant in the right iliac artery and vein. We use the short upper midline incision to extract the stomach tube that is resected. And with the XI system, you don't even need to move the robot around like we did at the beginning. We just redock. This is a short video showing the final part of the procedure. One of the questions asked before that we did not address was related to, do we use robotic stapler? We did on occasion for a difficult case, but most of the time, at least for the vessel, we use regular power stapler handled by people at the bedside. In this case, for the sleeve gastrectomy, the surgeon did choose to use the robotic stapler that are very good quality stapler. So now we are back to the right lower quadrant after moving the robot downward. That's one of my case done approximately a year and a half ago. Again, Gore-Tex suture size 5/0 for the vein and 6/0 for the artery. We actually found that suturing this kidney in obese individual is a lot simpler with the robot. And again, having the choice, we always would go for the robot. You can see that we have a little suture on the upper end of the vein, 5/0 prolon, just to facilitate manipulation. You will see the number. This is actually results that are better than our general series because they are limited to the last part of our experience. So we had more familiarity with the robot. You can see here our trick to make sure that we don't have any loose. We pull the last stitch up to actually make sure the anastomosis is watertight. That's how we do the arteriotomy in response to the colleague from India. It works very well. In non-calcified vessel, you have a nice arteriotomy in no time, just by putting a suture as a stay suture to pick up the artery and then cut with robotic scissor right below. The arterial anastomosis is done in the same fashion. with the 5-prol to avoid touching directly the renal artery, which is delicate. And again, it's a perfect magnification. We can magnify up to 30 times more than a microscope. And we have complete control of the situation. We don't feel in any way that the patient is shortchanged compared to doing the procedure in open fashion. Same thing, the trick to consolidate the anastomosis, we pull the initial stitch. Here is the revascularization. And finally, we finish with the bladder. I let this video go to show you a technical detail. We had trouble to do the anastomosis initial, but you can notice in this part, the bladder is actually retracted by the robotic fourth arm. I prefer this approach because it's a lot easier to do the ureter anastomosis. And because the bladder may retract inside the pelvis, the fourth arm puts you in perfect position to do it. So I tend to do all the cases with the fourth arm personally. The colleague initially asked, how come you had all this leak? Because we did not handle the 5 PDS properly. We learn, like in this case, I don't touch the part that is going to be part of the anastomosis and so forth. That's a final view and so forth. So we actually enroll 8 control and 10 sleeve. Not easy to do it because you need the alignment of planet. The patient must be clear for bariatric surgery, must have a live donor, BMI greater than 40. So, but we enroll these 18 patients. As you can see, they're very similar population, really no difference of note. But here is the difference. Both groups start with average BMI of 45, and the patient undergoing sleeve plus kidney transplant over 12 months drop about 12 to 13 points of BMI, going to about 31, 32, while the people that did not have the sleeve gain 2-3 points of BMI to finish at 47 average. Those are the tail of the weight and the BMI that are actually statistically significant in the small patient population considered since 3 months after transplant, which I think is quite remarkable. The operative data, the control, we had warm ischemia time similar, 50 versus 51. Again, those are all super obese. The operative time, it's of course longer on the sleeve side for about 1 hour and 20 minutes. The length of stay is shorter on the control. Now, Michael Prieto asked before if we had any particular accommodation for the business of the sleeve. What we learned from the first case is that sleeve patients do not tolerate all the pills we normally do to transplant patients right after surgery. So the only modification that we did to our protocol, for the first 2 weeks, all the drugs are given in liquid form. All the immunosuppression and other needed drugs are given in liquid form. Then after 2 weeks, they go back to normal. As you can see, we had 1 graft loss 1 year, and the complication, I don't even remember exactly what we had. I apologize. Interestingly enough, the GFR at 1 year was better on the study group of about 12 points of GFR, 50 versus 62. The clearance was better. The serum creatinine, 121 or 161, did not reach, of course, statistically significance because of the small sample size, but it's pretty intriguing to see that actually the kidney function at 1 year is better on patients undergoing sleeve and losing the weight. We, of course, try to look at the glycemic control, and we did notice a trend for a lower hemoglobin A1C on the sleeve group. Of course, as you all know, the sleeve gastrectomy cures type 2 diabetes 80 to 85% of the time. So as we expand our group to a larger number and we'll encounter more patients with type 2 diabetes, I think we'll see an even more impressive impact from the metabolic point of view. So we believe the bariatric surgery combined with transplant work as expected in weight loss and did not actually cause additional morbidity to our patient. We are very excited, and IRB actually asked us to stop the trial once we present the 1-year result. And now we are pretty much offering to all the patients undergoing a kidney transplant from living donor with BMI greater than 40. So we have done several other cases. Last one was last week. We have now a system that we can do even in a cadaver case. So our bariatric surgeons are willing to come in the middle of the night to do the sleeve, and then we do the robotic kidney from the cadaver donor. We are ready, but we didn't do any so far. I think the advantages are remarkable. Weight loss is very important, and of course, the GFR may actually respond favorably to weight loss. I believe that as we expand the series, we'll see significant metabolic advantage, but further study is certainly necessary. I think I'm done, and I'm ready to actually take a question, if any. I see several questions. All right. Asha Zimmerman, I believe. Sorry, Asha, I don't see the full name. 2 quick questions. Do patients have trouble staying hydrated after sleeve? The answer is that's a common problem after sleeve, and our patients are not immune. I mentioned the adjustment that we did for the medication. All the medication the first 2 weeks are in liquid form, and we have a special diet that is shared with the rest of the patient undergoing sleeve gastrectomy, and I think is widely adopted across the country. But at 3 weeks, most of these patients are on their proper diet. Second question, you just leave the kidney however it is lying, or do you position before moving the port? We do not try to position the kidney. Again, what we try to do is to make an anastomosis that whatever is the position of the kidney, full lateral, full medial, we still have a perfect flow. And the best position in the vessel is actually right on top of the vessel. That's where we try to stay. Dr. Ahmad Safra, I apologize. What's the highest BMI you may consider for combined sleeve and kidney transplant? Well, our record is BMI 62, and we have done several I-50. For sleeve, I think the largest that we did was about BMI of 51. We do not place a limit if the patient is otherwise fit for transplant and healthy. Did you see ATN or needed more early biopsy in the sleeve arm? The short answer is no. No, we didn't. Actually, I don't think we had any ATN in either the control or the study group. So therefore, no more. Any concern or change in management when you encounter complication from the sleeve, mainly leak? I mean, that's an important question. That's an important question that, of course, kept me up at night. What if we leak the sleeve? The reason why I actually proceed with the IRB, and that's the information that I provide to the committee that judge on our IRB, is that we have 5 consecutive years of sleeve gastrectomy without leaks. In particular, we never leak any robotic sleeve gastrectomy, which is becoming actually the preferred way to go in our center, as we have more robots available nowadays. Ricardo Gontillo, why do not do sleeve first, lose some weight, then do the kidney transplant? Absolutely, Ricardo, that's what we offer all the patients. When they come in and they have either BMI or greater 35 or any complication, we immediately refer the patient to bariatric. As I say at the beginning, only 20% of the patient agree to go see the bariatric surgeon. We have an inner city, mostly minority population. We are state university, and that's our patient respond to our approach. Our dietitian always offer bariatric consult for any BMI greater than 35. Of the 20% that say yes, at least to be seen, only 8% end up operating. So if the patient goes on cadaver list, we invariably try to do the sleeve first with no marginal success, unfortunately. And then we do the kidney transplant. When we have actually a living donor, we prefer to do the operation simultaneously nowadays, do the sleeve and the kidney transplant together. I think I exhausted the current question. Oh, I have another one from Sarpreet. Do you some dye for bladder identification? We do. We have a three-way Foley catheter connected with a bag with diluted methylene blue. And we distend the bladder as soon as we finish the revascularization of the kidney. I think we finished the, if anybody wants to comment or wants to actually talk to the group, please just raise your hand. In the meantime, Arun Verma asked, do you use any change in immunosuppression? No, we use our same protocol, which is steroid-free, tacrolimus plus MMF, with either time or simulate induction in relation to the risk of rejection of the patient. As I say, we do switch the formulation from pills to liquid form. Very well. Thank you so much for spending 2 hours with us. It's been a true pleasure. And we are always open if people wants to visit, wants to come for training, wants to talk with us. We believe that is good for the patient, and we want to share with as many surgeons as possible to expand the access to transplant for obese individuals that are very frequently minorities. Thank you so much.